All right. Hey guys, we're gonna go ahead and get started. You have me again today, Jen and Steph are out again. I am gonna introduce our speaker. She is virtual right now. I think everyone except I did not share this screen, so let me share this again. Oh gosh, never mind. I don't need to do that. I know it's not my screen. Okay. Okay, perfect. All right. This is Sharnita Harris. She's a psychologist with a passion for health disparities work. She's currently at Nationwide Children's, leading an expansion into Toledo, Ohio, and previously worked at University of Michigan. Her experience in primary care gives her a unique expertise of seeing how systems change is necessary to decrease average age of autism diagnosis and closing the race gap in identifying autism in Black and Brown children. We are so thankful for Dr. Harris to be with us today. That is a message from Steph. Just so you know. And you're good to take it away, Winner.
All righty. Good afternoon, everyone. You will all have to I'll have to apologize in advance. I'm working out a different office, so the technology is a little bit different from what I'm used to. However, I think with your patience and some grace, we can get through this pretty smoothly, but anticipate a few little hiccups as I try to navigate this technology. So I'm Sharnita Harris. As Sarah indicated, I'm with Nationwide Children's Hospital in Toledo, and I'll talk a little bit about my journey and then putting equity on the agenda. This is a topic that's really near and dear to me. And so I hope to make this interactive and collaborative as possible, and then we'll go from there. So we'll start just by setting the stage. I'm going to provide, like I said, a background, because I think sometimes it's important to know where a person is coming from and their experiences, just as a lens as how I'm seeing equity and the things that I've experienced, which has made me really passionate about putting equity on the agenda. I will define equity, and then we'll move into inequities in diagnosis and treatment, specifically autism, and then to round out the presentation by exploring solutions. I cannot see you all at all. I can't see the chat or anything like that. So if anyone can help me monitor the chat, or just feel free to, if you're on Zoom, unmute, or if you're in the room, shout out and I'll pause and we will go from there. I really want this to be interactive. There'll be a few things that we'll do throughout the presentation, break into some small group discussion, some large group discussion, just to make sure that we have time to hear from one another, because I'm looking forward to learning from you all today as well. Anytime we talk about health equity and these sorts of topics, they can be a little bit touchy at times. But I think if we set some ground rules, we can set a stage for a meaningful workshop together. So we want to respect each other, listen to understand, not listen to respond. And we want to have an open mind, create a space for safety. That's one of the biggest things with helping build Toledo, is like, I'm a big proponent of psychological safety. Like, we can move the needle if we can have meaningful conversations in a safe way. And the only way we can do that is if we feel that it is a safe environment. And so with that being said, refrain from personal attacks. Like, an opinion is an opinion, and sometimes trying to understand the opinions of others is a great launching point for how we can grow within ourselves. So here are the makings of me. I am from Detroit. That's where I was born. I was raised in Southfield, which is a suburb of Detroit. I went through Southfield Public Schools. Later went on to Ann Arbor, where I graduated with my undergraduate at the University of Michigan. It was my time at U of M that kind of put me on a path for psychology. I'm a first-generation college student, so going to college was like a big deal for my family. And I thought at the end of my bachelor's degree that I was going to be a psychologist. Like, oh yeah, did my 4 years, now I'm a psychologist. And one of my professors said, Sharnita, no, you don't become a psychologist because you did undergrad. There's other steps. And so she talked about those steps. And at that time, I had a different advisor who said, you know, maybe you should consider going into like a different program, like being a social worker. Particularly, you've mentioned you're not a good test taker. And if you want to go into a clinical psychology program, you're going to have to take a test. So probably social work is better for you. And so I wasn't at that time opposed to social work, because I did take a class with an educational psychology class, and the professor for that class actually had a background in social work. So I did go ahead and pursue a master's in social work. While in that program, there was a class, implication of psychological testing. And I said, I want to administer those assessments. And the professor said, well, to administer those assessments, you have to go back to school to be a psychologist. And I'm like, I thought I was at the finish line, but I was wrong. And so it came back to me having to take the GRE and applying to psychology programs. I ended up going into a school psychology program at Central Michigan University. I thought I was going to be a school psychologist. Nope, that didn't pan out necessarily. During our practicum experiences, I found, I don't know if I love the schools. So I ended up doing an advanced practicum at Children's Hospital of Michigan in their autism center. And that is where I fell in love with autism. I hadn't heard of autism in that way before. It was a new experience. And it just really just opened my eyes to like, this is the population that really makes my job worth doing. And this is what I really like. And so I did end up matching at Nationwide Children's Hospital, doing the intellectual and developmental disabilities track, where we focus on assessment and treatment of autism spectrum disorders and related disorders. I did my fellowship at Children's Hospital of Pittsburgh, not because I didn't love Nationwide, but my husband was in Pittsburgh. So I was like, we've been married for a couple of years, never lived together. Let me go check out Pittsburgh and see what it feels like to actually live with a husband. Ended up coming back to Columbus for my first faculty position, spent a few years there doing autism assessment before I was drawn away to do integrated behavioral health or integrated primary care work at the University of Michigan in the underserved clinic. And being at the Ypsilanti Health Clinic really, truly opened my eyes to health disparities in a way that I hadn't appreciated being in Columbus. At U of M, in my primary care setting, I was encountering 7 and 8-year-old, mostly minority children with, to me, pretty clear symptoms of autism, and asking parents like, hey, has anyone ever mentioned this to you? Are you, open to pursue an evaluation? And then that really like hit home for me that, you know what? There are a lot of health disparities around autism and the diagnoses and getting linked to treatment. And so that solidified it for me. I was then recruited to come to Toledo to bring behavioral health services as Nationwide expanded. They bought out Mercy Children's Hospital. So right now I am here, been here since January, and I have a team of 3 other psychologists and 1 social worker that works with me, and we're steady building. And again, there are a lot of health disparities, particularly in the Toledo area. And so that's a little bit of my background, and this is kind of an intro to why I am very passionate about health equity. And really my biggest goal is to really create an equitable infrastructure for children in Northwestern Ohio. And it has been such an awesome experience to be able to start at ground zero. It's kind of crazy. We're building the plane as we're flying it, but here we are. And I was hoping to also know, I've shared about myself. I would love to know who's in the room. I don't know how effective I'll be at navigating who's in the room, as I cannot see the chat. But if you could pop in the chat, or what's your discipline? What is your area of focus? Or if you are within the room, if someone kind of just wants to shout out what they're focusing in and what their areas are, that would be great. And if the LIN leaders have an idea of what the makeup of the room is, I'm open to hearing that as well.
So. Yeah. She should be able to see us.
Can you hear us and see us?
I can hear you. I cannot see you though.
Okay. Well, we're in a classroom and there's a bunch of us from different disciplines.
Okay.
There's a couple from psychology, speech and language pathology, occupational therapy. There's family advocates. There's pediatricians. There are developmental pediatricians. There's physical therapists. Who am I forgetting? Audiology, ABA, and self-advocates as well. So there's a bunch of us here.
Awesome. I love that we have actually a great mix. So that is helpful. And I see public health trainees. I see.
We also have genetic counseling as well.
Perfect. Thank you so much for that help. So let's see. I'm going to go on to the next slide if I can maneuver. So what word comes to mind when you hear equity? And feel free to shout out or put into the chat. I do know how to navigate over to the chat now. Once one person typed in, it kind of popped on my screen so I can find it. What kind of things come to mind when you hear equity? What words pop out for you? And feel free to just shout out.
I feel like for me, it's not a word, but more of like that picture where everybody is given the correct access and support in order to receive like equality in the world. Like if you ever see like that fence picture, cartoon picture, that always comes to my mind.
I see Carrie said access. Awesome. Yes, that fence picture may pop up soon. Providing equal opportunities. Awesome. So let's move forward. Let me see. I think it's the worst because there's no mouse in here. Okay. So if we think about equity, equity is allocating resources and opportunities according to an individual's needs, which is different from equality, which is more focused on giving everyone the same opportunities and the same resources. The thing that we really have to understand with equity is it recognizes that no two people are the same. A person's needs may be determined by their individual situation, and some people may need more than others or less than others. Is the chat box on the screen? On your screen, it makes the
Yes, it is.
Oh no. Yep, let me try to move it out of the way. All righty. Thank you, Sarah. And so this is another depiction of how we can kind of see equity versus equality. If everyone has the same bike, the poor child in the front can't even reach the pedals, then we have the tall person, and then if we have someone that's not ambulatory, that's going to impact them differently. And so we'll move on to the next piece. I am afraid that I did not press the audio when I started the screen share. So I might have to stop share and start share with pressing the audio so that we can hear the video. So I'm going to take a moment to reshare my screen with the audio selected, and hopefully this does not cause too much disruption. Can everyone see the video still? And I'm going to go ahead and press play.
We can see it.
Perfect. Thank you.
Article 1. Universal Declaration of Human Rights. All human beings are born free and equal in dignity and rights. Sounds pretty good to me. But if we are all equal, then why aren't we all treated equally? And is treating every person exactly the same always the best thing to do? What I'm actually talking about here is the difference between equality and equity. They sound almost the same, but these words mean slightly different things. First up, what is equality? Equality is recognizing that as human beings, we all have the same value. This means we all have the same rights. We should all receive the same level of respect and have the same access to opportunities. This isn't just a nice idea. There are actual laws supporting this, so it's kind of a big deal. If we know equality is about treating everyone in the same way, then we can think of equity as everyone achieving equal outcomes. Okay, it's like this. We all have the same value and deserve a good life, but we all start from a different place. And we are all wonderfully different and experience the world in our own unique way. It's because of these differences that we sometimes need to be treated differently for us all to live safely, healthily, happily, and equally. This means that we need to look at what individual people and communities need in order to achieve equity. So, while treating everyone the same may seem like a lovely idea, it may not always result in achieving equity because we're not all the same. In fact, sometimes treating everyone the same way can be a disadvantage. Like expecting everyone to read the same book written in French. Even though some people may not understand French, that could be pretty confusing. Think of it like this. Equality is giving everyone the same ladder to pick these juicy mangoes. And equity is recognizing that not everyone can pick the mango using the same ladder. Ah, that's better. The mangoes are our opportunities and stuff. Sometimes we need to make choices and take actions that help protect our community, like washing your hands and wearing a mask when you visit someone really sick. Even though we might not be the ones in danger of getting sick, by doing something small, we can help look after everyone. So, it doesn't matter who you are, where you come from, what you look like, what you believe, think, or do. Every human has the same value and is deserving of the same opportunities. Creating a world that is fair for everyone is up to all of us. We can help by looking out for each other, showing one another respect, and thinking about the different ways others may experience the world.
All right. So here's the image that was briefly already touched on in terms of showing the difference between equality versus equity. However, do we think this depiction is too simplistic? Paul Kuttner is a social activist who would argue that this image kind of does oversimplify the difference between equity and equality. He suggests that the problem should not focus on the height as an issue, because this alone would suggest that the inequity was inherent to like the smaller child who couldn't see over the fence. And so when we're doing diversity, equity, and inclusion work, we have to be careful not to blame an individual for their inequities that they may be experiencing by making the inequities a characteristic of the individual and not really focusing on the context of the situation. And so he did recreate the image with some people standing on lower ground as a metaphor for like historical oppression. So it's not because you're shorter, but it's just you're on a lower ground, and some of the spectators can see over the fence and some aspects of the fence are higher. Again, a metaphor for present day systems of oppression. And so we really want to focus, like when we're thinking about equity, what is the context of the situation? So now we're going to talk more specifically about health equity. So health equity has been defined as striving for the highest possible standard of health for all people, giving special attention to the needs of those at greatest risk of poor health based on social conditions. Health inequities, however, are systematic differences in the opportunities groups have to achieve optimal health, leading to unfair and avoidable differences in health outcomes. It's also been stated as differences in health status or the distribution of health resources between different population groups arising from social conditions in which people are born, grow, live, and work, and age. So really, we have to understand what are some of these root causes of inequities. And as we get to understanding these root causes, we can think about systematic changes that can be made. So some root causes that we'll explore that are worth exploring is air pollution. So if you're in a place where you're not getting good, clean air, that can lead to future diagnoses such as being labeled having asthma. Then we also think about housing conditions. If you're in old housing conditions where there's lead paint, or if we think about in Flint where there's the water crisis, those things all impact our health outcomes. Poverty, having access to great education is going to be a little bit different than having poor quality education systems. Discrimination, and then even the foods that we eat impact our health and employment opportunities. Of course, racism, and then access to health insurance. And see, this is a nice depiction because it shows how those roots of inequity, which can be seen at the base of the tree, can lead to these disparities in health outcomes. These root causes are particularly problematic because they are avoidable. They lead to unfair differences. And if we can address some of these root causes and giving everyone same opportunities and equal access or more access, depending on the areas that they need to be lifted up in, we can lead to more equity in our healthcare. What I love to do is do like a 10-minute small group. I know there's some that are on Zoom, but then there's others that are grouped in a class. If you just get into small groups where we'll discuss what are some of the root causes of inequities commonly experienced by patients within your population or within your community. And if you're a provider, discuss your comfort level with discussing health inequities with your patients. Is this a routine practice that you do when you're providing care? If you're a parent, are health inequities addressed during your child's care? And if so, how is this being done? And then what are some of the barriers to addressing health inequities in your discipline? I'll stop the screen share, even though I hate to stop it because Lord knows how challenging it might be for me to navigate it, but I want to be able to kind of be able to see so we can have some time to share out and discuss. So if each group has one person that kind of wants to be the spokesperson and talk about what your group really touched on, that would be great. And so we'll take about 10 minutes to discuss, and I'll stop the screen share. Bear with me as we get back to screen share after this. Let me find Zoom.
You guys want to get into like groups of 4? I think it would be like 4 groups. Maybe 1 is 5. I can like come around.
And again, the focus will be what are some of the root causes of inequities commonly experienced by your patient population or within your community. If you're a provider, do you feel comfortable discussing inequities with your patients? If you're a parent, is this something that's routinely done when you're taking your children for visits, whether it be to the speech path, to their primary care, to a subspecialty clinic? And then what do you think are some of those barriers to addressing health inequities? I guess I could leave the slideshow up for the question piece, and when we discuss, I'll take it down so you can actually see the prompts. If I can get over here to the screen.
Hi, are we in a breakout?
Right out in place. Show her. Like look up at a card. So I feel like it's hard, especially to feel comfortable access to specialties. So we don't use these a lot of time. It's like, like watching, like maybe diagnostic stuff, but I don't overstep what like, you know, it's so like. Sure, there's to not ask that. Partly in which, you know, I scratch. Yeah, I have that either. So I feel like if then you get it. I right. So and they have to be hard now to like it's just everybody like a lot of universities. And then even like I found like being really upfront of like what why I put that information like this is like a deeper information. Well, at the end of this, so just yeah, like kind of like I ask everybody these questions. And yeah, like that again, it's nice. So for yes, additional supports outside here. And we can oh, sorry. We don't have. Not hard. That's not really asking. They might be. I feel like that means I've had supervisors. Like I know for us, like when things like then if they have like I like somebody has like so I do that. That's what we can offer them to people or they're like high value business. This balance of like I want to give recommendations that are better. So there are a lot of right now, and I also don't want to support assuming what they're so it's like such a hard pass. Yeah, like yeah, and we're like, no, we're able to figure it out. Why did you put this on here? Exactly. Yeah. So that's like super personal. It's like weird. But it was like a lot of that higher that we like other costs and we're having oh yeah. Especially when there's like trying to talk to hospital for their how frustrating it's like 5 minutes of recorded. Yeah, they're closer to this, you know, yeah, yeah, for sure. I feel like has a lot to do with education services. Like one that's going recently is like child age, like how we done it's a color and it's yeah, because those are all like people who are like I think that is a structural issue. I'm writing my skin out in this area. But it's like proven. A lot of children have color don't remember their autism diagnosis. Because they're first diagnosed with like because of the yes.
It's hard to like, I know with our research, those are the families who hard looking, aren't even going to see the first time, or like below it, yes, like talking out, or the families questions where like, you know, what's
That is the problem or if there is a concern.
where they so it's like looking out, like, you know, this is the most difficult thing I have to do, I have a hard time getting to like getting to the hospital or transportation, she's like always talking about their issue.
How they're here, they don't answer. And so I think
That's it.
too, like it becomes.
And then they have to call back. So it's like, that's just another.
Is a barrier.
They might take somebody
Like,
struggling, have ability during a day to call.
And so
we can do things like,
financial, but also cancel or miss
sessions.
and like with OCD.
Yeah, that's
Whatever. Just really like transportation.
The most motivated clients are gonna be for a variety of like, you know, and like when I was actually like, see like I think behind the fact. Things like that are just, you have flexible schedule, like having a flexible schedule with the first.
So I think like that's.
Even though we
big
may be
barrier,
very,
that like
very
sometimes we just kind of, it's like,
always complex.
sort of stuff that conflict, just like running into a wall. Appropriately serving
Our way.
with your patient who wants to kind of like break that down.
Hey, here's all these
And
things.
I feel like,
How do you feel about
and I have this. I have a suggestion that you probably very few. You have it for a lot more. And then
But
I'm
it's
sure
sort
you
of-
are.
Me sort of have like no show offs.
I think it's 4 times.
And then they.
Yeah.
It's really hard, so a lot of this, we have a lot of. You know, problems with transportation and time. It's just hard for them.
Especially like, assume that like you're having a conversation.
There's some families where. If you're like bringing it up, not like booked out for 8 weeks. I have therapies, but like it's like 5 weeks, but then those slots get filled and we're like.
Yeah.
And these office schedules. And that feels like another.
But I can't.
All right, it sounds like the conversation. Does anybody need more time? It sounds like the conversation is kind of wrapping up. Maybe we can pull those
You always say that, you always do good.
break rooms out, maybe give them another minute and we can pull them. Oh, perfect. Sarah,
Yeah.
we are on. It will close out in 45 seconds. We're insane.
Yeah. That's a very hard one. When having that train of thought. You know, cause I've had that.
For next year, I feel like if we do this again, I want to get with Steph and get down there. Particularly, it seems like there was a lot of interesting conversation going on to make it in person.
But that's the really nice. But I guess.
And then by next year, I think I'll probably have enough support to be able to leave a clinic. All right, so I love to hear from each group to just go over our questions, which the first was kind of like, what are some of the root causes that you're commonly experienced by your patient or in the communities that you work? And just discuss kind of the key takeaways or the areas that your group raised. Who would like to be our first volunteer?
All right, can you hear me?
Yes, I can hear you.
Okay. So we kind of talked about the people in our group are we had two people who work in sort of outpatient specialties and two self-advocates. And so from the provider side, we kind of talked about as specialty providers, I think this is something that doesn't come up as much because just access to a specialty provider is an issue of equity in itself, where some patients just don't have access to providers for therapies or, you know, things like audiology or speech pathology. And so, you know, that's something that we talked about a good bit. And then we also kind of talked about how, in terms of barriers as providers, it can be really frustrating because a lot of the time it feels like there are things that are not necessarily within your control. So things like transportation and, you know, access to internet and, you know, how many supports are available like within the school system and within the community that the family has access to. You know, like sometimes it can feel like, you know, you're only really offering suggestions that may or may not work. And we also talked about like patients being a little uncomfortable with discussing the inequities they face, or you know, feeling like a sense of defensiveness or shame about that, about having that inequity, even though it's not necessarily their fault. And then from the patient and like self-advocate perspective, we talked about how sometimes there can be a barrier in like not knowing how far to push against certain inequities that you feel like you're experiencing, and you know how much can be done for you when you sort of push against those inequities that you're experiencing.
Absolutely. Thank you so much for sharing. Other groups?
No.
Hi. So we were a group of 3 psychology graduate students and then 1 speech pathology student. And we talked about a lot of the similar things that what Raz said, some structural and kind of institutional barriers related to scheduling, evaluation slots, prioritizing younger children when we know that for children of color and girls, they're more likely to be diagnosed later in life, in childhood, and how that can kind of perpetuate that inequity. We talked about how for most of us, for the psychology providers, it's our diagnostic interview templates are pretty templated, and we kind of get those from supervisors. So sometimes it can be kind of hard to fit in or know where to ask about inequities that the family might be facing or barriers they might be facing. Typically, I think the consensus was that we kind of lump it in with talking about just general family stressors, and that we tell families that these are questions that we ask everyone to make sure that we're providing recommendations that work for your family, and so that we know what other stressors the child might be going through in our evaluation. But that it can be kind of a tough conversation to have and to fit in. But a really important one. And then, yeah, I think just talked about other barriers that Raz spoke to related to insurance, availability of school services, transportation, childcare for other kids, and work schedules getting in the way of access.
Absolutely. I have a follow-up question for you. You mentioned it's the diagnostic assessment is somewhat templated. How comfortable would you feel to talk to your supervisor about, hey, I noticed that this kind of was missing from the current template as is. Is this something that's worth adding, or what do you think if we could expand the template to include? How comfortable would that feel as a conversation point?
I think a little bit uncomfortable. Also, I think just as people learning, right? But I think it's totally an important thing that we all need to be doing and including very intentionally in our interviews. So I think something
I
I
appreciate your honesty and your feedback on that, because I also do a training with the faculty about being open to feedback, and it starts with our supervising psychologist or supervising whoever is in a supervisory role, again, creating that psychological safety to receive feedback. And I imagine that it's not easy, because I've been in conversations with colleagues who say, oh, Sharnita, we don't have time for that. That's good. The appointment is already long enough. And it's like, you're training someone and you don't perceive it's enough time for it. And so therefore, what does this could inadvertently suggest to a trainee if we don't figure out how to create solutions and work in these things that are important to discuss and consider? So I was just curious about what your thought was in terms of bringing it up and there's definitely hierarchies there. And so I get it 100%, because I wouldn't have pushed back at that point in my training as well.
Yeah. Thank you so much. And I think a lot of it too, like what you said, is for me is time. Like I want to make sure that I'm being efficient with my time in a visit that's already super long, like you said. So yeah, that is something that would be like a primary worry for me, but it's a really important thing to spend our time on. So yeah, thank you.
Thank you. Any other groups to share? I know there was a breakout room group. I don't want to share.
Yeah, hi, this is Carrie. I wasn't sure if anyone else, because I can't see anyone from the classroom, if they were going to talk, so I didn't want to just jump in. So in our breakout room, we had public health, child life, pediatrician, and a family advocate. So a lot of the stuff that was already discussed, we talked about those as well. We really talked a lot about like language and communication barriers, both like receptive and expressive language for our patients and caregivers. Different policies that are set up in place, just hurdles to seeking out care as far as like specialty care, needing a referral. If you don't have a primary care doctor, you can't get to the specialist because you need a referral in place. So kind of jumping through those hoops, just bias and discrimination of healthcare providers, housing, transportation, availability of consistent resources. So it being in a rural area, not having the same level of services that you can access. Julie shared from the parent perspective, myself included. I have never been asked about any challenges or barriers that I'm facing. Same with Julie, she's never experienced that. Talked about, you know, is this the assumption based on a provider that you don't need help, or just not a standard practice for anyone? And then, you know, just the thought of, if these questions are not being asked, maybe why is that? And thinking, you know, could this be because if someone does need access or help, like taking ownership, and whose responsibility is it to help that person when you don't have those resources and you don't know what to do for this family in that moment? And so are we not asking because we don't know what to do, or the thought that these are not a kind of, I can fix this, these are, you know, systematic issues, versus how can we help someone, one person or one family at a time?
Absolutely. And I think sometimes, just an opinion, some things that are not necessarily comfortable, we might even avoid. Like, this is a comfortable topic. So, or I perceive that maybe asking could make the other person feel uncomfortable. And so therefore it can be easy to kind of like push it down and say like, well, this is the focus of the visit, so let's just sweep that part under the rug. But anecdotally, I will say that sometimes when I get in these conversations with families, they're happy, like, no one has ever taken time to ask me these things. Wow, like you really care. And not that, trust me, now being in Toledo, in comparison to Columbus, I feel like there were a lot more resources. But here it's like, there aren't as many resources, but I still feel the need to do it, and so that we can figure out like, how can we collaborate with the other partners in our community to kind of help fill the gap. Particularly if I'm starting to hear recurrent themes when I'm talking to families about what are some of your challenges? What are some of the social determinants of health that you're experiencing? And it's a small step, but I think it can be meaningful. It's like that rock in the water. If we keep dropping, we're going to erode that rock away. So don't be afraid to get in there and ask these questions, because for the family, it could mean a lot that you're actually considering the intersectionalities and the multiple things that they could be facing. Work with me as I switch back over to the slideshow. I promise this is like going to be the struggle of the day, going back and forth between. So I think I'll definitely need to come in person next time. Of course, slideshow from current slide. Then I have to swap it. So give me a second to swap display. All right. We should be all set. And if anyone is sending a million notes, just pop and say, Dr. Harris, we see all of your million notes. All right. So now let's get more specifically into behavioral health disparities. Children and adolescents and transitional youth face mental health inequities. About 20 to 25% of children experience a diagnosable behavioral health disorder by age 18. Yet these problems often go undetected and untreated, particularly among non-white children and those from low socioeconomic backgrounds. Youth exposed to disproportionate levels of risk factors related to poverty, food insecurity, violence, and discrimination, as well as racism, have increased risk for depression, trauma-related disorders, substance use, aggressive and disruptive behavior, anxiety, and eating disorders. So it's important to keep that in mind. And behavioral health concerns have been exacerbated by the global pandemic, putting children who are already disadvantaged at even greater risk. This is particularly problematic because untreated behavioral health problems in childhood increase the risk of persistent behavioral problems into adulthood, unemployment, and physical health. And then this becomes a vicious cycle that's very hard to break. Then we're going to move specifically into inequities in autism identification. Yes, if you didn't know, which it sounds like I was able to hear some of the conversation, there are differences in diagnosis rates. Autism is diagnosed less in African American and Latinx children. There are also differences in initial diagnosis. With children of color more likely receiving a different diagnosis initially before they go on to receive their autism diagnosis. So that is of concern for sure. And I've definitely been able to see some of this in practice where we're getting disruptive behavior disorder or oppositional defiant disorder or ADHD before we're going for the autism diagnosis, which in some cases, maybe there is a co-occurring, but it's the fact that there's this striking difference in white children going to receive initial diagnosis of ASD first over the children of color who go on to receive other externalizing behavior diagnoses first. Let's go on to the next. When we look at differences in age of diagnoses, African American, Hispanic, foreign-born, or children born to foreign mothers are more likely to experience delays in receiving an ASD diagnosis, some children being diagnosed closer to 6 years of age. I've definitely encountering that more, having been into primary care settings where I am, asked to consult on a particular child, and I'm like, this kid definitely has a missed autism diagnosis. And so I think, and I'll talk about this more in a future slides, is that being embedded into primary care offices will hopefully help close that gap in between age of diagnosis, especially if psychologists are able to, you know, be in a well child visit, and not as there's something going on, but just preventative. And so we can see if they're not meeting milestones or they're failing MCHATs. We can kind of be there to kind of closely monitor that particular child. There are gender differences as well, which someone in the group kind of already highlighted, that girls are getting diagnosed later. What's interesting is that the age of concern is around the same age, yet girls go on to receive that later diagnosis. As you can imagine, if we're diagnosing children later, they're missing out on treatment opportunities. A lot of I don't know about in your area, but in our area, that window to receive early intensive behavioral intervention is quite narrow. So if we're making a diagnosis at about age 3, maybe 4, they may not even benefit from getting into an EIBI program, because we have wait lists for 1 to 2 years to get into these programs. And so it's really critical that we make an early diagnosis, because again, Black and Latinx children are experiencing a lag between when they get the diagnosis and when they're able to access the treatment. Individuals from lower SES backgrounds are getting less hours of ASD treatment services. And then we have those language barriers, mistrust, and the stress of the process that really impact. I can recall working with a family where the child was diagnosed with ASD, and our recommendation at the time, it was a little one, she was about 2 years old, where mom, though she wanted the in-home ABA therapy, she said, I don't know if someone coming into my home will lead them to try to take my child away from me. And so I'm like, where do we get this idea that if we come into the home, we're going to, or the provider will call Child Protective Services? And so these are a lot of like compounding variables that some of our parents are facing. And I will say, I have been in situations where there are patients, like children of color, where that concern of maybe the dad talks in a little bit more of what's perceived aggressive way. Hey, should we call CPS? And I'm like, whoa, like cool our jets, nothing has happened. Culturally, there can be differences in how we communicate, but it doesn't mean that there's any signs of abuse or neglect. And in these cases, I have to call it to the forefront. What are you seeing? What are you feeling? What is causing you to feel that you need to call on this family? And those are conversations that can be tough to have. I'm on to monitor the chat. I don't know if I've seen something pop up or not, but I'll take a quick second to, oh, nope, that's nothing new. And let me move the chat box. Okay, so let's keep on rolling. And also going to be cognizant of the time. I know it's almost time to approach a break. And so we'll keep going until about 2 o'clock and have our break. Differences in physical health have also been highlighted in the literature. Individuals with ASD diagnoses have decreased life expectancy, increased morbidity, more likely to use an emergency room department. Minorities with ASD are less likely to receive subspecialty care. Again, that's something that you all are already highlighting in your small group discussions. And there's poor physical health in adulthood as well. In, what was it, about 2001, the American Academy of Pediatrics had recommended universal screening for all children. That initial policy was later updated to include universal screening and administering, standardized developmental assessments beginning at 9 months of age, as a way to kind of identify that early identification leads to better outcomes. However, Hooray found that only about 30% of parents reported completing developmental screeners. And then 37% of families reported that their child's development or developmental surveillance, so that's just the provider asking, like, do you have any developmental concerns, had occurred within that past year of their visits. And then only 19% of families talked about completing a developmental screener and having some developmental surveillance. So we'll go into some solutions, but this is one area that is of concern, is the developmental screening component. And then it becomes a particular concern because who's less likely to be identified? These are children of minority backgrounds, children of single mothers, those who come from families that have lower socioeconomic status or whose parents are less educated, and then children who have public insurance or who are uninsured. And so this leads to barriers in that identification. And what are providers saying as barriers as to why aren't we routinely screening within our primary care settings? One big issue is time constraints, which, being in subspecialty care, I really didn't truly understand the time constraints until I got into the primary care setting. I'm like, okay, yep, that's a lot to get done in one visit. But trying to think creatively, like, how can we help support getting the universal screeners completed, which I'll talk again later into the solution section. Some of the other things that the primary care providers discussed during the survey was that they had inadequate reimbursement for conducting formal screeners. Now, being on the administrative side, I do see how some of the care that we provide is influenced by dollars and cents. When I was more so on the front line doing the interventions and providing the service, I wasn't as privy to how much really goes into what makes money and what makes sense for large hospitals and corporations. Then we also have language barriers. We have lack of medical office staff to help perform these screenings. And then we have to think about again, this is also something that was touched on, the lack of treatment options. So we can screen and identify these areas of concern, but if our next step is less than ideal, or we don't have a next step considering the community that we're in, that can make it hard. That can make it really hard to say, hey, we understand you have these concerns, but we don't have anywhere to send you. We are about 3 minutes to 2, and our next thing was going to be a breakout session to kind of talk through another small group discussion. I think it'll be good to take a break here, and then when we come back, we can get into some of the discussion piece and go from there. Sarah, you can inform me about how long the break usually is, and I'll make it fit with whatever time we're working with, okay?
Do you guys want to do 5 or 10? 5? Let's take a 5-minute break. Let's come back at 2:03, 2:04. Talk to you pretty well. Oh, yes. You're right. I was not. I don't have to watch her. Okay. We did there, so I think that's everything. Yeah. What? Wait. Oh, yeah. I haven't seen any of my years, so I have to see the Okay. Yes. At least. If it's the Northwood. I would love to sit out and. Not like. No, it's just like, this is the caterer, like regular. I don't know. But it's. Yeah, I make real. Really long. I know, it's like a part of it, right? I would.
I'm doing okay.
Yeah. Oh, yeah. They have that.
What? Yeah.
Likes to dodge. Likes to dodge, can pull your leg a little bit, huh?
Too. A little bit. I, are you gonna be in IT's meeting today?
Someone dressed as that,
Oh.
and then. But.
I think it's good.
Run into you with their head, yeah.
My wife is on next week. He, or she, first night, so she was. We voted this morning at 6:30. So. Yeah, she was I've been up for a while.
Yeah, I think. So, you know. That's fair.
Oh, yeah, yeah, I got married.
I just know how to.
I got married.
A little better. I always used to burn it.
Yeah, I've been pretty.
Oh, what were you?
We've been doing pretty well. Here on University of. Yeah. It's a bit-
Hey, now you can be, every year, in a friend can be the same thing.
No, not too far away. Yeah,
Oh, yeah. That's very good.
they're pretty similar commutes, everything like that.
They do take out. Oh, you don't. Yeah, I was. I like.
I was gonna say, I was thinking, today is just like the first day forever that I walked out of the house. Like, oh. Yeah.
Oh, sorry, let's. No, that's not. No, okay, only. And what, you can say. Yes. Fishing center, and we all look. We'll go on, ask her. She'll- I think you look old, but I do. Yeah. Doesn't matter, but you know, I'm like, like 20 years. I think I like 20-year-olds. You're baby. I was like, you're not. Oh, yeah. Oh, here to the top, okay, and then I know it. Do they hear anything on it, like, mental? Choose how to spend you want to do it. Yeah. Think it's not so.
All right, so let's do another small group discussion. I'm pretty interested in this. I can share my screen again. Of course, don't grade me down because it takes me 5 minutes to get back to the screen. I promise. I'm not good with technology, but I'm a little bit better than what today is showing. Okay, there we go. From current slide. Now I have to switch the view. Okay, so let's jump into those same breakout groups. That's fine. I want to hear a little bit about how you all use standardized screeners when preparing for appointments. Why or why not? If that's something that's common part of your practice, or if it's not. And then what percentage of your patients, if you know, were referred to your services as a result of concerns identified on a standardized screener. So like if they're not doing well on their ages and stages, is that how they make it to speech therapy? Or are you getting as a subspecialty because they failed the MCHAT? And if you are a parent or a caregiver, do you recall completing any standardized measures at your child's visits? And what kind of screening tools were they using? And what steps were taken after the screening if they, came back with an abnormal screener? And then share any creative approaches to increasing universal screening that you all may be a part of or have had conversations around in your respective disciplines. And we can take about 5 or so minutes to go over those questions and go from there. Five to 7 sounds good. And I'll leave them up, and when we discuss, I'll take the screenshot down.
Modified checklist for autism.
Okay. I just know it's one that, yeah, we failed and he's developmental basics.
With that, I think how helpful it is really depends on the provider who made the note. Because sometimes they'll be like, MCHAT indicated some concerns, and they won't say anything like that.
Some of them are, it's really bloated.
Yeah.
Just fantastic.
So I think with notes, like I always look for it, but some providers aren't writing notes in a way that helps the next provider to know what to do with that information. So I like that kind of information. But there are a lot of kids who don't have it. Like even like the 5-year-olds, I'm like, I don't know that anyone's ever given us.
Yeah. But never, like you guys. What are those? What
they
and
do.
half of what's happening is foster clinic for others, and it's from their clinic. And seeing so I feel like and then it's like define something that you see are a lot of ways. Referrals from so the PCP to the nutrition, and then to
I see a lot of
the
those.
so like it's like another provider by the time you get to the end, like question if you have trouble if like their procedure like you care everywhere, can you just not doing that? Not like sometimes like they're more like compared to pain versus yeah, are they meeting around?
And like the balance. And so we have a couple of experience that way. Other hospitals are still maybe do it. I'm selected to that time people who are here. Like people here it's or maybe I just can't find it, like I have to be. Yeah, we don't really the information because most of the time we try to they like any class speech language, but we don't use that when they have
You know, that makes sense. Just look at your baseline, like you and then the doctors research that.
It's.
Just like whether it's when I feel like we don't tell our baseline, we don't like. Whether it's that way. So that makes sense. So it's like, with the only information that we have, okay, this is what they are, but we don't go with that mindset. That makes sense. So you like don't look at the checklist, you don't want to be like, are you guys gonna end up with the options like, yeah, like, yeah, we want to make those very. That makes sense. Yeah. I wonder if it's everyone the same. Okay. Like sort of first, like specialists. Yeah. But I know some like right, so it's right, but I see these like. Yeah, we have some. Anyway, I'm seeing that it's. Everything and then feel like, okay, they. I'm like, so like, everybody around the room, you guys are fire, we don't like, yeah, like, yeah. Yes. They're for sure, yeah. But I said, other than some of those. Yeah. Look at all. And then the pediatrician. Go through all. Yeah. Medical information. Yeah. 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 I was like, I'm eating like really. It's like get excited when I see certain days. I'm like, I guess it's gonna be. But once you're done hair wash, they're just so tough. Yeah. Oh no, I it was good. I was like but like some of my patients like were evaluated like a while ago and are coming back. Yeah. She's really good. Of like also learning a lot about yeah. Not trying to answer the last question, like I was wondering what you were living, you know, like you're staring at the clock, you're staring at the back, staring at you teaching girls. So share any creative approaches to increase diversity. I looked at the surveillance program, which we're talking about. But I also think like, yeah, staffing issues, if someone has to like hand them an iPad, use it up. Or print it out and give it to them. I think if they're doing that. I don't think they were trying to implement something, maybe trying out like college students related to like DEIJ screening. Where it was like done with the kiosk, so like before you check out, you would like answer these questions on the kiosk. Like news running the and everybody's right message, but it's public news and on the way out. They have to follow up. I should be on the way in. Yeah. But I wonder if like giving families like different options, like someone can call you. Yeah. Yeah, like I know what you kind of chat. You know, which are you disabilities. Yeah. Yeah. Like it goes back to like that is I don't get the sense that it's off their child, like there's often a choice in I'm gonna choose as the provider. If I have time to see. Yeah. I will say like, I don't know, I worked in families usually have a lot of time. Yeah, no, they're not like us. Use this time as possible, but then someone has to give you like be a desk. And then some places be like, it's not like it's sometimes like a lot. Yeah, and then I think it's also to give it to like when I'm at the doctor's, like what do I do over this? Like, so and then someone has to that was another thing that makes us like yeah, like after the visits or like missing items. Think of like how long we spend checking the violence. Yeah, and we still have something. Yeah, I don't think it would be violent level.
All right. It sounds like there's a lot of awesome discussion going on. Yes, we can close out that breakout room and come back and just kind of share summaries of what your group talked about. And I would really love to hear if there are any creative solutions that maybe are working really well in your settings, to bring them back to our settings too. So would love to hear from the first group whenever you're ready.
We talked about in our group how we often review standardized screeners if they're available. They're not always available. We just also talk about sometimes maybe they're available, but they're not written about in a way that's as helpful. So some, like, I see the MChat a lot, and sometimes it'll just say like the MChat indicated some concerns, and that's all that's written. And so there's not much to go on. But we also had some different perspectives about some people don't look at them for the sake of not filtering everything they see in the appointment through a specific lens, like if they think an autism diagnosis might come out. In terms of creative approaches to increasing screening, we thought of maybe offering families different formats in which they could complete a screener, or if they could use some of their like time in the waiting room where they're just kind of sitting to fill out something. But we didn't have much else besides that.
Are any of your places doing that in the waiting room?
I don't think so right now.
Thank you for sharing. Anyone, any other group?
I'm in the virtual pullout room.
Okay.
I do a lot, my office, which has 4 providers in it, does all of this, the recommended standardized screeners, but not all the providers in our community do so. And I see a lot of the referrals for children with complex health needs and developmental needs, and it's rarely a result of a failed screening that gets them to me.
Okay.
Which is really frustrating and unfortunate. So one of the things that we're trying to do as a community is translate developmental information into the predominant languages that are present in our community, which tends to be one sort of unified group. And we're just in the process actually of doing that this week so that we can have the families more comfortable with divulging information about the child's development. But there are definitely some cultural barriers and cultural differences in child rearing that are impacting how we review that and that kind of thing. And I'm an old parent, and a couple of us are, and we did not complete standardized screenings. And in my case, we did not do developmental profiles of any sort, just even open questions during my 24-year-old son's earlier years.
Gotcha. Mm-hmm. Thank you for sharing. Any other groups want to share before we move on?
We talked a little bit about how, at least in my field, I'm in audiology. So a lot of times kids don't get referred because of a failed screening. They get referred for other concerns. And then here at Cincinnati Children's, we give the MChat to kids when it's developmentally appropriate, just because a lot of the times if there are concerns for speech and developmental delays, we're the first ones that they see before going on to other therapies. But we kind of talked about how sometimes like a difficulty that we have with the screeners is that sometimes they can be not entirely accurate just because sometimes what the parent sees at home and then what we see in the clinic are totally different. Like the environment can be scary, or just just the unfamiliarity of it all can really have such an impact on a child's behavior that it just makes the screener and then the experience just not line up very well. And then also just, things like, again, sort of like, if parents are, just like not able to give a report that really gives us a comprehensive view, or like if they come from a very blended family or, have like different areas that they spend time in, we're getting lots of different reports from parents and pediatricians and teachers and things like that, it can make the screener a little bit, feel a little bit less reliable.
And to your point, one of the creative solutions that I tried to pilot at University of Michigan, which we didn't end up getting enough funding, is so in Ohio, we have Help Me Grow. Well, every state has their Birth to 3 program, but we were trying to get a developmental specialist that would like work for like Help Me Grow or to early on to be embedded in our primary care office so that they could do to take some of the heavy lifting off the PCP to do the screenings with the family, and also having some of the developmental activities that the screening might talk about, like stacking blocks and things of that nature, because what we were finding is that the kids did have some of these skills, but parents were not endorsing them, not because they, didn't have a good handle on their kids' development, but they didn't have blocks in their home to observe their kids stack. And so they were saying, no, like they can't do this. But in actuality, it's not because of a lack of skill, it's just because of a lack of opportunity. And so that's something that I've always kind of thought about, like, can we embed developmental specialists, particularly I'm biased right now within primary care settings, to help with some of these things. So can we see is this a true abnormal screen, or is it just based off of parent report due to not having that opportunity? So I want to move into exploring some solutions, particularly when we're trying to put equity on the agenda. We've talked about some of the concerns, but let's talk about solutions. For me, having done subspecialty, and now I'm going across all areas at the moment, but having also the background in integrated, I feel like this is a great approach in helping increase access. So research shows that integrating behavioral health professionals into primary care settings can help reduce some of the stigma that is experienced. It provides a familiar environment so that families are more likely to follow through with the services. And what's nice in our clinic is that I'm able to pop right into the visits with the families to discuss any behavioral health concerns. And the pediatricians are so happy that we're here because it takes up some of their time. About 25% of primary care visits are due to a behavioral concern. And so it's nice to be embedded, to the point that I've started to see so much autism in this setting. And our wait list for our autism center is about a year or so, that I've ordered a kit for primary care to be able to do some autism specific testing, an ADOS kit, and some of our other autism measures to be able to assess directly. Am I on the wrong screen? I'm sorry about that. So this is going to be, like I said, this is the biggest piece for me, is trying to work the screen share. But yeah,
We can also, we can see your notes. I don't know if that was something that you wanted on the screen.
No, I think I'm just in a wrong display. So I will do, let me try to share again, and you'll have to kind of tell me if you can still see them, because on my end, it's hard to tell which screen.
You're all good.
It's good now?
Yes.
Which is so crazy because it's the same view for me. I promise it has been a day, I'll tell you that much. But I promise I'm usually not this bad with technology. Okay, I'm probably like a C+. Right now I'm getting vibes. But thank you for that, because on my side, I just kind of see the same thing. I don't see the displays are exactly lined up. It shouldn't be too much more flopping back and forth anyhow. So there might be one more time, Sarah, where you have to tell me what's going on, because I don't know. But as I was saying, so I mean, to be able to, there's been some, so I do the autism center as well. There's been kids that we have referred out to the autism center where I am due to see them. They've been on the wait list for about 8-9 months. They missed their autism appointment, but I've been able to catch them in primary care, where I'm like, okay, you're here for a different visit. I have an opening. Your PCP is much concerned about autism. You know, are you available to stay? And we'll go ahead and do the autism evaluation. And the providers have been grateful. The parents are grateful. Because of one anecdotal story, I had a family come out to the autism center, and it's not in our greater like Toledo area, it's out kind in a suburban area. And the mom, she said, I didn't want to cancel. I spent cost $45 to take a lift out here. And I said, well, of course, try to help him find solutions. What about medical transportation? You know, what you have in Medicaid, if you set it up, you got to set it up in advance. She said, oh, I did that. I set up the medical transportation. They didn't show, and I wasn't going to miss the appointment. And so as I saw the arrival time that they weren't here, I just called, I did a lift, and that's how I got out here. And so leaving that appointment, I felt terrible because she had to pay $60 on her way back, because I don't do a lot of ride sharing, but whatever, it was like a peak time or something like that. And she waited for an hour to be able to get this particular lift to come get her. And it just highlighted so many different inequities, even within our system, that I'm hoping to fix. Like, we don't have the cab vouchers out in our suburban clinic, where the clinic manager said, Sharnita, this has never happened before, where a parent was stranded. And I'm like, well, what about the cab voucher? She's like, we don't have those. And I'm like, oh boy, there's a lot of things that we need to change to make our services more equitable, especially if we're referring out. And so one big change that I made was like, hey, I need all of the ADOS testing tools right at this primary care site, so that our families that take the bus or take the cab or walk to the visits can just walk short routes. They're not trying to take $100 round trip lift to get out to where we're servicing them. And that was really eye-opening for me. So I'll go on. Again, universal screening is going to be something that we definitely push. The pediatricians will play a critical role in detecting developmental delays. The biggest piece why the push for universal screening is there is because research has shown clinical judgment alone detects less than 30% of children with developmental concerns. But if we implement these standardized screenings, for better or for worse, even if there's inconsistencies across environments, once we actually start to do some of that follow-up, just getting that eye on that child increases 70 to 90% just by doing universal screening. And so I'm definitely recommending that universal screening is implemented, because we know that early detection plus early intervention leads to better outcomes. It reduces future behavior problems, health problems, and future learning problems. And again, this is just a timeline of kind of how the American Academy of Pediatrics recommended universal screening and how this has been helpful. When I was at my previous site, I was really proud of their numbers. They were like, the screening rate was like up at between 63 and 75%, which I thought was phenomenal. So want to open it up for a quick large group discussion, so that we're not breaking in breakout rooms and I'm not stopping and opening and sharing screens. If your 9 a.m. intake treatment hasn't shown to their appointment and it's 9:15, what are some of your initial thoughts about this particular family? Just open it up to the floor. Anybody can feel free to jump in and speak and say their initial comments. And of course, give honesty. I don't want this to be a judgment zone. I want this to be like, this is kind of how we're thinking about things. What are you thinking?
For our practice, it really depends on the type of appointment they're missing.
Okay.
If they're not coming for a recheck of an ear infection, we're not going to take the time and call them. If it's for something like a pneumonia, we will, a more serious infection. Or if it's a developmental screening, I will pick up the phone and call them and attempt to reschedule. And if they're late and they're a family of one of our community people, sometimes we see them whether they're late or not, because they have adherence to appointment time difficulty. And sometimes they're just so late that we have to reschedule them and hope for the best. It's not an ideal situation.
Absolutely. Any other thoughts, or how do you handle it? Because I'll be honest, sometimes if my 9 o'clock and it's 9:15, I'm like, oh, I got an hour to try to catch up on paperwork. It just really depends.
Yeah, I think my thoughts change dependent on how often this late arrival is occurring. Like if it's a one-time, so I'm an occupational therapist. If it's a one-time patient or like the first time I'm seeing them or even eval, I feel like, not that my opinion changes of the people by any means, but it's a little more understanding, like they're navigating where they are. But I also have had families consistently show up and we're not allowed, we are, as practitioners, are allowed to choose if we want to see a patient if they arrive after 9:30 or like the 30-minute mark, because we see them for hour appointments, depending if it's an eval or just a treatment. But I've had families that I consistently see for 14 weeks and they still show up at 9:20, even after like reminders like, hey, we're only getting 40 minutes of therapy. Because you're 20 minutes late. Is there a different time we can work out? So, but it can be like frustrating because you don't get to address all of the goals you want to in therapy, or the parents like, oh, I haven't seen progress in this area. I'm like, well, yeah, we haven't worked on it in 5 weeks because we can only do so much in a therapy session. So, yeah, it's just a conversation, and then trying to work with their schedule too. Like, is there can we find a different time? What can I do to help make this better? Is there a home program we can set up instead of addressing this at therapy? So just trying not to be irritated when they show up late is sometimes hard.
And that's honest. That is honest and valid concern, because also you are wanting the child to make gains and you're wanting to hit on all of your treatment targets. So definitely understandable. Any other thoughts or comments? I think for our clinic, the biggest thing, especially like for ADOS testing, is when they show up with other children and we really don't have a setup, at least at the moment, where we can offer childcare. Now, when I was down in Columbus, we did have a psychometrician office. The psychometrician can hang out with the older child or the other siblings, give them some coloring sheets and those pieces, but we don't have the manpower while we're in this building stage. So sometimes that is one thing that's like tricky for me to navigate, but I don't want to deny the kid their services because there are multiple siblings that have to come to the visit. And so I think that's something hard that I've encountered to navigate. Anyone else having this with the multiple, because like you need the parent in the ADOS to, especially depending on which module, but I love any solution that's out there.
I think for audiology, we run into this problem a lot, just because when we have families that come with multiple kids, there's only so much space in an audio booth. If you've never been in one, it's like a glorified closet. And we also need it to be quiet, which having multiple children in a small room where only one child is like allowed to play or do anything is not necessarily a great formula for that. So we sometimes will have audiology aides or other audiologists that sort of watch the children out in the waiting room, but that's also not necessarily ideal because you're asking the parent to leave their children with someone that they don't know. But it is something that comes up a lot. And so things that we do are typically, either having somebody watch them outside or, offering quiet activities for the children to do while in the booth while their sibling is being tested. So like playing with fidget toys or coloring, or if they have a tablet, being able to play on the tablet with no volume. And also kind of like we kind of gamify it where we're like, you have to be as quiet as possible. And then at the end, you can get a sticker or a prize or something. So we try to make sure that the sibling feels included and, doesn't just feel like they're being made to be by themselves and like be kind of left out of their siblings' care or testing experience.
Absolutely. And I think that's the biggest piece is like that inclusivity, not only for the sibling, but for the parent, because a lot of times the parents feel, I don't want to say bad, but they have to do what they have to do. And if that is their situation and circumstance, trying to make the environment as inclusive as possible. Okay, so we're going to do one more activity where I'm going to stop the screen share. Please help me when I get back to screen share. So I'm going to navigate over to my other screen. If I can successfully do this. If you have a electronic device on you, this would be a good time to bring it out because we're going to play a little game. And I'm going to get this game loaded up. And I'm going to share my screen again, but hopefully it will share on the game mode. Okay, so let's see. And it's so terrible because I'm like looking at a screen that's higher than the camera, so it makes me feel weird. Okay, can you see my screen? It should say like waiting for players in the center. Does anyone see that, waiting for players?
Yeah, we can see that.
Oh, and okay, great. So basically, go over to www.kahoot.it, enter in your game pin. You can use your real name, you can use the alter ego, however you want to fill it out, that is fine. We're gonna play a quick little game and then kind of talk about how it connects to what we're doing. I love these like characters. So right, oh, with the pancakes on top. I love it. Okay, so I think we got a good amount. I'll give a couple more seconds and then we'll go ahead and get started. So you're gonna see a series of pictures and all you'll need to do is choose the correct picture, okay? Let's get started.
Oh. Why did I think
Okay, if you selected B, you are correct. Let's go to the next one. There, I forget they give us a scoreboard. All right, let's go on. And no cheating, no Googling. If you chose B, you're correct. We're gonna keep moving. Okay, good job with that one. Let's keep going.
Yes. I would do what's missing. Yeah, it's really bad. The nose color? Oh, yeah, nose.
Let's see how you guys are doing. Nicole, have you played this before?
No.
Okay, we're going to the next one. We got a few more.
Oh, I. Oh. Oh, I always. Right. I know otter.
All right, I think we got 2 more left.
I need everyone to know Brad was sitting behind me and goes, is it really chic filet?
What moms call it target. Oh, it's not called pretty. Nice, Brad. It's the Chick-fil-A. Chick-fil-A. Oh, right. I thought he didn't. I wasn't allowed to include him on. I love.
All right, here is the last one.
Oh, yes. I know, I remember. And I was like, no. My whole life was. You're just helping everybody out.
All right, let's see what we have. What do we have?
Mine says never give up. You're doing so well. Good mindset. Give me a motivation. Mindset incredible, but I only got 4.
All right, Raz, good job. Now, Raz, have you ever done this before?
Have you done this before?
I have not. I pay too much attention to too many things that do not actually matter, except for right now. This is what I was training for.
This is what you trained for. You conquered it. Really, I like to do that activity as just like a fun breakup and mix up. But the point is, sometimes we can, as providers, as parents, as whomever, feel like we know and see the whole picture and are very sure and very certain in how we view a kid, a situation, a family. But really, we could be missing that small detail, and these small details matter. And so it's important for you to be an expert in your field, but also know that parents are experts in their children and vice versa, and really working together to find those little missing details. And how do we, make your best for that particular child as the individual, as the common denominator. And so I just wanted to break up a little fun in here to add to this piece, but really as a take-home message of, we could think we know everything, but still be missing one small thing that can make a difference in how we conceptualize or treat or interact with a kid or a family. And so we have just a few more minutes left, and I do have a few more slides that I want to get through, and we'll kind of go through them a little bit quickly. So again, have my back with the screen share. If I'm sharing the wrong area, please let me know and we'll go from there. It might take me 5 more minutes and our time might be up before I can even pull the slides back up. So let's see. All right, here we go. Can we do it? I think she can. If I completed a doctoral program, I think I should be able to have a master's now. Oh, goodness gracious. Okay, so let's see where we are. And it's just like, I can't really get back to my main screen. All right, do you see my notes or you don't see my notes?
We see your notes.
Okay, hold it. Let's see. Now we're gonna swap. Now, what do you see?
We see your slides with no notes.
I'm getting there. Okay, so one study that I looked up and wanted to highlight is, particularly if we're thinking about putting equity on the agenda, and I definitely don't want to make this a Black versus white, but one area that I've seen in a lot of the clinics that I've worked with is that Black families have a little bit of more obstacles as they're navigating autism diagnoses and as well as autism treatment. And so Burkett did a study and understanding like what is needed when working with Black families, particularly around autism diagnoses and seeking that care. And what was highlighted in the surveys that they conducted with these families is that relationships and respect are 2 very important variables. Building personal relationships with families can go a long way. So we want to, and then how do we do those? Is through willing behaviors, helping families navigate the care system, providing emotional support, calling families back and following up, seeking answers when unsure. So if there's something that's going on that you're unsure about, like following up and saying like, hey, what did you mean by this? Or how can I help in this situation? And then planning for their child's behavior in clinic. I've had some very challenging behavioral kids. And if I kind of know what they like, oh, you love SpongeBob stickers. Oh, I've got some SpongeBob stickers and we're going to use this token board to, earn these stickers as you're displaying good behavior in the sessions. These things can make a big difference. Some of the barriers could be judging parenting practices. Culturally, there can be differences in the way kids are, the language that's used, body language that for some families is a total norm, but in some work environments that's like, oh, wait a minute, this is an area of concern. Questioning parents' ability to deliver therapeutic recommendations at home. I have worked with colleagues who will say like, I don't know if the family can execute this recommendation, but I've challenged back. Why do you think that is? What are the concerns that you have? Personally, I don't like to assume what a family can and cannot do. So I give like 3 different things. Like this is tier 1, tier 2, tier 3, what will work best for you? Because I can write an amazing recommendation, like A+ work. And if it does not resonate with the family or something that the family cannot implement, then it's not going to be beneficial for that family. And then what are some of the signs of respect that were discussed in the article? Listening and acting on family concerns for their child, showing care for the child above all else. I think when we showed that our common denominator is the child and wanting what's best for them, that can go a long way. Recognizing that the family provides better, that no one provides better care than a family. Now, I know somebody might protest in some cases around that, but overall families, what I found is families often want to do the right things. And even if they're coming up short in our eyes, we often have to consider what are some of these variables that are impacting these families' decisions. If a family is trying to get basic needs met, like food and clothing, sure, maybe our rating form that we ask them to complete a part of their autism evaluation isn't top priority. It can be frustrating for us that we want these forms and you haven't returned them, but it also can be okay, I did want to do this form, you didn't return it. Hey, maybe I'll fill out a cards instead, and I can still get some valuable information and move forward with our diagnosis. Being flexible and incorporating family suggestions in the treatment. Again, every family wants to feel heard. Respecting the generations of the family, because believe me, I don't know about you, but I definitely have grandmothers that come into the appointment and will say, we ain't doing that. And I'm like, well, why not? Like, let's talk about it. Hear me out. What about what I'm saying doesn't jive with you? I'm into my career now. So even when I see shifts in body language, facial expressions, I just like to call it out. Like, I said something you ain't like, let's talk about it. Like, what about what I just said rubbed you the wrong way? And or what about that I just said that you are not like gelling with and you are not about to do this particular intervention? And so we can get to the conversation. And this is with any family that I work with. As soon as I see a shift in body language, I'm like, okay, what just happened? Tell me, what am I doing? What am I saying? What just rubbed you wrong? And just trying to go the extra mile for families. We probably can go through signs of disrespect. The biggest thing, because we're at time, and these other slides are ones that you can kind of go over, is promoting inclusivity. You do not know how it could feel for a family to come into an environment that does not show representation of them. I just had a colleague say that they went to go see, this is a total aside, Disney on Ice, and her niece is biracial, and she kept saying, please be a Black princess, please let a Black princess come out. And I guess Tiana was not a part of the cast, but this particular on Ice event, for whatever reason, I don't know. And she was like, I watched my niece just so devastated because she didn't see any princess that looked like her. So this is even getting down to what kind of toys do we have in our office? What kind of pictures are in our waiting rooms? Because when everyone is not represented, it does not feel good to not see someone that looks like you, or to have you in those spaces. That can be hard for children as well. And I'm an adult, and that can be hard when I don't see my children represented in offices and spaces that I go in as well. I'll stop here for the sake of time and for opportunities to ask questions. What I'll say is another big thing that I want to highlight is that a lot of this can start within our homes, also within how we interact and treat and work with colleagues as well. If microaggressions are taking place, call them out. I think doing the work means taking action when actions are needed. And so definitely, I will say personally, this has become easier over time, but it hasn't been always easy. When I was hired at University of Michigan, to come and to open up the integrated primary care for one of our urban clinics, on my first day, they were showing me around, and I was greeted, "Are you the new secretary?" And in that moment, it was like, wait, why do I have to be the secretary? Like, actually, I'm the new doctor here, Dr. Harrison. Nice to meet you. Where would I be sitting? And so those, previously, I might not have been able to have a remark or say how that comment could have made me feel. But as I get more comfortable in this work and navigating these spaces, it's easier to talk about and call out what is there. And it's important to have allies as well to be able to help disarm microaggressions or anything like that that could come up. So you got to think about yourself as the provider, as a practitioner, and then as whatever other role that you play, and as a parent if you're raising children as well, so that we can create a more equitable society. And it starts with us. I'll stop there. Any questions? I'm sorry that the timing, I think I wasted more time trying to get back to the appropriate screen share. So hopefully next year I can come if you have me back in person, and we won't have to do all of these technology switches and all of those things. So any questions, comments, concerns? Anything? And I will say, as another piece, if you are someone who is going to be a champion for like diversity, equity, and inclusion, don't be afraid to jump into it. Know that it can be a challenging area to jump into, but it's so necessary. And don't worry about saying the wrong things, because you will. I will. I could have said the wrong things today, but it's about taking correction and feedback and applying it. So I can't encourage you more to have these conversations, build these committees, and not for it to be a check mark on a list of tasks or things to do, but actually making it a true part of your work and how you treat families and how you treat colleagues and how you work with individuals around you. All right, 5 minutes left, but we can get out early. I'm glad that you learned a lot, and I'm so sorry that I bumbled through this technology. I should have just worked from home today, but patients called. The work had to be done in office. Oh, I hear clap. I see clapping. I can't hear it, but I see clapping. So I guess I didn't. Don't grade me an F because of the technology. Well, thank you so much. It was definitely a pleasure. Like I said, if Steph has me back for next year, I would definitely, hopefully it can be arranged far enough in advance that I can close the clinic day down. It's hard to close clinics, but I would love to join your group in person.
Thank you.
Thank you. I appreciate it. Take care. Have a good one. Enjoy the rest of your day.
Yeah, I know.